Well, you've already heard a large introduction to a lot of my thought processes. So CVP, I was actually kind of surprised when I was asked to talk about this. I thought, can we still talk about CVP? I am going to try to show you a slightly different insight that I have myself as I think about this some more. So two papers. One was one in Critical Care Medicine 2006, a useful but not so simple, and I'm going to emphasize that. And one that's just recently come out, Maurizio has asked me to write this one, and he gave me this question, which actually has helped me alter my thoughts on this. So I'm starting off with this slide because it always drives me nuts. This is one by Paul Merrick, where he looks at the question, does CVP indicate the magnitude of vascular volume? He reviews a pile of studies and says, no, it doesn't. Well, why would you expect it to? As you just saw, there's a stress volume and an unstressed volume. It's affected by the heart working with the circuit, so of course it doesn't. And I can't understand why this is even raised. He then goes on to say that a single value doesn't tell you what's going to happen. He even includes one of my own studies. And of course it doesn't. So the problem is, CVP is not an epidemiological question that you're going to analyze by looking at a meta-analysis. It's a physiological question, and you have to understand the physiological principles. So what does CVP indicate? Does it indicate preload? What determines it? What are the technical issues in obtaining it, and how do you use it? That's the question you really want to answer. So the first point, it's readily available in most patients who have central lines. So you can actually get an estimate from the neck veins, and you should probably try getting used to it. It's cheap, simple, there. Okay, it's not telling you everything, but it's still a useful thing to follow, as I hope to show you. What about this question, is it preload? No, it's definitely not. Not the mean, nor even the end expiratory value. However, a single value at a single point in the cardiac cycle, the base of the C wave, is the best estimate in my mind for preload. So here's a CVP tracing with really good resolution. There's no ECG to help you, but this is the A wave. You can see a little C wave. This is the V wave. And the mean of this pressure is 5. This would be inspiration. This is inspiration. If we look at the top, it's 10. The bottom, it's 1. So 10, 5, 1. At 10, you might be holding back on fluids. At 5, you might be adding fluids. And at 1, you're saying, oh, maybe I need fluids. Very different answers depending where you draw the line. So which one is right? Well, for me, the one that's right is the base of the C wave, or if you can't see it, the base of the A wave can be a reasonable substitute. Let me explain. Here's the same tracing, and I'll just draw this part, bring it down, expand it, and let's put in a right ventricular tracing. So what the base of the C wave gives you, and we've got to put in a pulmonary artery pressure, it gives you the final pressure in the ventricle before the onset of systole. So a useful value to give you that final stretch to the sarcomeres before contraction. So that's the proper place to make the measurement because it's the best representation that we can get of a preload. So it's the pressure before the onset of systole. If you have an ECG, again, nice A and V waves, you can draw a line down from the ECG, which will also give you that from the S wave. It's slightly shifted because this is an electrical signal, and the CVP is a hydraulic signal, so it's moving more slowly. What about this one? Here's a person on volume control. They breathe in, trigger the ventilator, breathe out. So here you make the value at the end of inspiration, at the end of the expiration. And if you can find a C wave in there, you can see it's not that important here because it's all about the same. At an end expiration, so you avoid the changes in pleural pressure. Okay, what about the Frank-Starling relationship? So what they said is the greater the initial stretch of the wall of the heart, the greater the force produced and the greater the output. The preload is the force which sets the initial length before the contraction. Yes, it is a length or it is a volume that counts, but preload is a pressure. So it's the pressure which, given an elastance, gives you that final stretch. The significance of this is what goes in, what goes out. So in the Starling curve, as you increase the filling pressures, the output goes up until you reach a plateau, which is created by the diastolic properties of the ventricle or the pericardium as it surrounds the heart. Importantly, there is a sharp limit to the function curve, and volume above this only provides what I call wasted preload, because it's not stretching anymore. What's the significance of Starling's law? Consider the situation where a stroke volume of the right ventricle is 101, and that of the left ventricle is 100. A 1% difference. Pretty small. You know, if your car worked with that kind of precision, that'd be pretty good. At a heart rate of 70 beats per minute, in an hour and a half, your total blood volume would be in your lungs. You can't have a 1% difference between the two ventricles. They have to be perfectly matched. And what Starling's law says is what goes in must go out. So it provides the fine-tuning to match things. But Starling actually does not use the word preload. Here's his preparation. So he has his heart. This is taken out of his 1914 paper. So he has a heart. He's measuring pressures with simple manometers. It's going through a pressure with a Starling resistor to actually create a fixed pressure downstream. He warms the blood, and he has this reservoir, which is the equivalent of a mean circulatory filling pressure. And what he does, he adds fluid to this reservoir, which comes back to the heart and creates a pressure depending upon how the heart is functioning. So the reservoir volume and the height used to determine the filling. With the CVP, the actual value that you would measure with these manometers depends on how well the heart is handling that return. So it's not like he actually puts volume into the ventricle. He puts it through a circuit upstream and lets the heart handle it, which is what your body does. You don't come along and say, okay, I'm going to give this injection right into the RV. It goes into the whole system and creates a driving force that comes back. So what the volume is doing is stretching a venous compartment. And what the heart is doing on this, it's releasing that brake and is reducing the downstream pressure, which I wouldn't call a resistance. It's a downstream pressure. The resistance, to challenge you on that one, the resistance is the change in pressure for flow. So it's a downstream pressure, or back pressure. What the heart does, it reduces that downstream pressure, allows this area to drain, and of course it has another very important role. It has a restorative function. It has to put the volume back again. But it can only handle what's coming back to it. It can't do more because this is where the bulk of the volume is. So we have a cardiac function, Starling's law, a return function, which is the characteristics of drainage, depend upon that stress volume and the resistance draining them and the downstream pressure. So the return function is drawn with a classic Guyton venous return curve and the cardiac function as a Starling curve. And the beauty of this is, as Guyton showed us, you can now use a graphical analysis to solve these two mathematical functions, a return function and a cardiac function, and you get an intersection point, which is the CVP, the right atrial pressure. I'm going to use them equivalently because there's really trivial resistance from the big veins to the right heart. So that's what's actually determining it. So it is the preload, but it's being determined by the actions of these two functions. So what's the significance? So preload by itself is not a major player in normal physiology. It's more of a response, as I've just said, to the actual situation. So for example, this was a study we did on normal subjects exercising, and we measured the right atrial pressure with a catheter sitting just at the superior vena cava and the heart, and we estimated cardiac outputs from their oxygen consumptions. They start at rest with a central venous pressure, which is a little bit below zero. As soon as they start pedaling, it goes up. But strikingly, as the cardiac output is going up dramatically, there's almost no change in right atrial pressure, which means the heart is keeping up perfectly with what's happening, and you don't have to use a continuously increasing preload to maintain the cardiac output. This even occurred in transplant patients when we studied them in this paper. So during exercise, the cardiac output increases fivefold with very little change of central venous pressure after that initial rise. So CVP values can make some diagnoses very unlikely. If you were to come to me and say, oh, I think this patient has tamponade, pulmonary embolism, RV failure, and you told me the CVP was 0, yeah, okay, it's possible. Maybe they bled and you had some other things going on, or maybe there's another left heart problem, but by and large, those are unlikely diagnoses. You can't rule out left ventricular dysfunction, but those other explanations are not going to be good. If you told me that the CVP was low, and or which way I've got here, high, and then you tell me that there's shock because, this may be the wrong way, but if you told me the CVP was high and you thought the diagnosis was hemorrhage, well, yeah, again, it's possible, but you're going to have to do some fancy explanations. What's a high CVP? From a study we did, around 10 to 12 millimeters above a level 5 centimeters below the sternal angle. Above that, you can respond, but it's much less likely. So how to use the CVP? So it tells you how the heart's interacting with the return. Low values indicate likely room for fluid. High values indicate that the heart is not keeping up with what is coming back. So trends are the most useful. If you have a fall in cardiac output with a rise in CVP, so here you see it, so the CVP went, so the cardiac output went down, and the CVP, I got this the wrong way. Sorry, messed it up. I was tired, I guess, when I did this. So in this case, if you have a fall in cardiac output with a fall in CVP, in this case, no, that's what I wanted, I'm sorry. That tells you it's a pump function. If you have a fall in cardiac output with a fall in CVP, so they're now going in the same directions. Sorry, this would be a rise. I got totally confused. So if you have a fall in cardiac output, look at this, with a rise in CVP, then as you can see, that tells you it's a pump problem. If you have a fall in cardiac output with a fall in CVP, they're going together, that tells you it's return problem. Don't look at the labels, they're wrong. So in this case, you know volume is going to be the answer. In this case, you've got to fix the output. It also tells you that Starling's law has been tested. So if I have a rise in CVP and a rise in cardiac output, I know I'm on the steep part. And if I have a rise in cardiac output with no change in CVP, even about 2 millimeters of mercury, then that tells me that they're not responsive. So an important part of the CVP is telling you that when you gave your volume challenge, you actually tested Starling's law. Because if the CVP didn't change, I don't know whether I gave enough or I don't know whether it's not working. And the type of fluid is actually not important. You just want to know that you actually raised the CVP and tested Starling's law. So in summary, CVP indicates how the heart is dealing with what is coming back. Its most powerful use is in following trends and the response to therapy. A single value does not predict well the response to a bolus, but it tells you that you've tested Starling's law. It's still very useful when you're managing your challenges. And high values and low values can actually be helpful diagnostically and making some diagnoses very unlikely. Thank you.
Thank you very much, Sheldon. Excellent presentation, and thanks for correcting the resistance versus the resistor. Any questions from the audience?
Back pressure, you want to call it.
Sorry?
You want to call it a back pressure.
Back pressure. There's one question.
Jukka Takala, Bern. Shelley, the example you gave on the exercise, and you said that there's a trivial increase in CVP. Actually, if you look at your values, you went from negative to +5. So in fact, your CVP increase was almost as manifold as your increase in cardiac output. So my question is, for the mechanism of this increase, do you think that there could be reflex activation of shifting the stressed volume, the unstressed volume to the stressed volume, which increases the CVP in this context?
Absolutely. So there's two parts to it. So one part is, if you notice, it rises immediately. We actually have a separate publication within the first pedal. The first time you pedal, because you end up squeezing by the muscle pump blood out of the leg, and it rises by about 2-3 millimeters just when you take the first press. So that is just simply squeezing it out. So it's a mixture of stressed and unstressed because it's the muscle. But then afterwards, certainly you are continuously decreasing capacitance and recruiting unstressed into stressed. So that for sure goes on during that process. And it's going to be matched to the same sympathetic response, which is increasing heart rate and changing resistance and distribution of flow. And so what's amazing is through most of that, they really are going, if you look at that figure again, from about 10 liters to like almost 30, there's very little change. So all those things are coordinating magnificently at the same time. But we didn't evolve in a week. We evolved over 100 million years or so, and so there was lots of time to work that out.
But at the same time, it also shows how significant already a small change in the CVP is.
Oh, well, that's actually a really important point. If I drew out the venous return curves, I always draw them as those little things. When you try to show it during exercise, you have to hugely expand it. So in fact, during exercise, trivial changes in CVP actually end up having very, very huge effects. But the point I want to emphasize is not actually the CVP, it's just the stuff coming back and getting handled well, and it's a mixture. But oh yeah, no, very small changes have huge effects on cardiac output, absolutely. And it changes. So if you're in shock, you get much little benefit from the change as compared to when your system is really coming back at a high rate.
Thank you very much, Shelley, for this presentation. We move on to